In this session, we'll be discussing the airway management. Airway management is one of the most important issues and procedures that we perform in the intensive care unit, and any patient who needs artificial airway most probably will be in the intensive care unit. The purpose is to keep air passage patent to allow airflow during the breathing, whether it's inhalation or exhalation. In case of CPR, airway will be managed by positioning the patient head by head tilt chin lift maneuver or by jaw thrust if spinal cord injury is suspected, as we see in those two figures. Oropharyngeal airway is a medical device used to maintain a patient airway. It does this by preventing the tongue from either partially or completely covering the epiglottis, or what we call it tongue swallowing, and it comes in different sizes. The indication of oropharyngeal airway to facilitate the insufflation CPR for a patient with a thick tongue because of any other diseases or any problem or because of trauma, and it helps in draining saliva and fluids in recovery position. And we have to note that the airway or oropharyngeal airway presence does not remove the need for recovery position. Insertion of oropharyngeal airway. The airway is then inserted into the patient's mouth upside down. Once contact is made with the back of the throat, the airway is rotated 180 degrees, allowing for easy insertion and assuring that the tongue is secured. Risk factors for using oropharyngeal airway. If patient has a gag reflex, they may vomit, as that might cause aspiration and block the airway. When it's too large, it can close the glottis and thus close the airway. Improper sizing can cause bleeding in the airway. So to choose the proper size for this patient, just measure the airway as shown in the figure, from the mouth of the angle to the angle of the mandible. Another type of airways, which is nasopharyngeal airway, and also called nasal trumpet. It's a tube that is designed to inserted into the nasal passageway to secure an open airway. Indications for nasopharyngeal airway. Nasopharyngeal airway are sometimes used by people who have sleeping apnea. In emergency situations where an artificial form of airway maintenance is necessary, but it is impossible to be used on an oropharyngeal airway, just like oral bleeding. Suction of the upper airway in an unconscious patient. It is contraindicated to insert nasopharyngeal airway for a patient with severe head injury or traumatic brain injury or facial injuries, or if this patient has any evidence of basal skull fracture. Insertion of nasopharyngeal airway. Usually the insertion will be by the respiratory staff because this airway is under their care. Use lubricant, insert until the flared end rests against the nostril. Endotracheal tube or ETT. The endotracheal tube is regarded as the most reliable available method for protecting a patient's airway. The tube is inserted into patient's trachea in order to ensure that the airway is not closed off and that air is able to reach the lungs. It's used in general anesthesia, intensive care, and emergency medicine, and it's used for airway management, mechanical ventilation, and as an alternative route for some medications if an IV line cannot be established. Indications for using endotracheal tube. Cardiac arrest, in which ventilation with mask either impossible or ineffective. Respiratory arrest, with the oxygenation with non-invasive method is inadequate. Patient unable to protect the airway, like in a cardiac arrest or in coma. Also, it could be used with general anesthesia. Types of endotracheal tube. Oral, which is inserted through the mouth. Nasal can be inserted through the nose. Cuffed, which has a cuff. Uncuffed does not have a cuff. Double lumen tube, which is like a double tubes together attached to each other. That's used in case of thoracic surgeries. Tracheostomy tube, that's for long-term use. Tube range in size from 2 to 10.5 millimeter in internal diameter. This figure shows us the cuffed on the left side, which is cuffed endotracheal tube. On the right side, uncuffed endotracheal tube. And this is the double lumen tube that is used in thoracic surgery that has two ports to ventilate each lung separately. Endotracheal tube. The intubation procedure, which is a doctoral procedure, but the nurse has a big rule, an important rule to do for this procedure. So we will start by washing the hands and wear our PPEs, assess airway, suction the patient's mouth and nose if needed, put the patient in a proper position to open the airway, and we have to consider if the patient is having any spinal cord injury or any trauma. Insert oro or nasal pharyngeal airway if needed. Prepare oxygen circuit and demonstrate techniques of ambu bag. Hyperoxygenate patient with 100% oxygen prior to insertion of endotracheal tube. Premedicate patient as indicated, and usually we give muscle relaxants and sedation plus the painkiller. Insert endotracheal tube using laryngoscopy to visualize the vocal cords, and that the laryngoscopy procedure should be done by the doctor himself. Confirm tube placement by using stethoscope to hear the air entry in both lungs, oxygen detectors, CO2 detector, and X-ray. Mark the tube at the teeth or lip level, and that depends on what's useful in your area. Discuss the intervention if there is incorrect position of the tube. Insert a bite block or oropharyngeal airway along the endotracheal tube to prevent biting by the patient. Secure the endotracheal tube in a place. Reconfirm tube placement. Hyperoxygenates and suction endotracheal tube and pharynx. Chest X-ray to verify confirmation of correct position. Monitor saturation and identifies variables such as normal level as per age groups. Check tube every 4 hours. Alarms parameters set and put on all the time. Verify ventilator setting. Combitube. Combitube is a special type of endotracheal tubes, and it's an advanced airway that can be used inserted of the endotracheal tube. Can be inserted by any healthcare provider. You don't need to be expert to do that. It can be inserted without visualization of vocal cords. That's why you don't need to be expert to do that. This is the Combitube, and it has like a double lumen tube. Once it's inserted, it can cover both trachea and esophagus. How does it work? It is inserted blindly. It will go through either esophagus or trachea. So one of the openings will be in the trachea and the other one will be in the esophagus. Inflate balloons with air. Proximal balloon should have 100 ml of air and the distal balloon should have 15 ml of air. Ventilate the patient from port 1 and then port 2. Assess the air entry and decide which one is in the trachea to be used as an airway. The other one will be blocked. Laryngeal mask airway, and it's an advanced airway that can be used instead of endotracheal tube, but mainly it's used in theater. Endotracheal suction. Endotracheal suction is performed to maintain a clear airway and optimize respiratory function. It's carried out when a patient with an artificial airway such as a tracheostomy or endotracheal tube, patient cannot cough and void pulmonary secretions. Suction should be performed as needed, not regularly. The equipment needed for endotracheal suctioning You need suctioning apparatus, appropriate size catheter, gloves, apron, eye protection, gallipot and small bowel, saline, and water solution. Pre-oxygenate the patient with 100% saturation. Always suction the throat and perform oral care before the tracheal suctioning to prevent VAP or ventilator-associated pneumonia. Suctioning not to exceed 5 to 10 seconds for each pass. Remove the catheter from the airway safely. Means when you are removing that, remove it slowly and without vacuum. So you have to release the vacuum. Evaluate for complications associated with suctioning, such as desaturation or tachycardia, or might be bradycardia. Notifies the physician if any complications observed. Thank you for your attention.